And that is a very nice also sanity check for me, because you tend to maybe end up in a bubble of believing that diagnostics is the first thing people think of when they wake up in the morning. And I do realize that is not the case, at least not most mornings anyway. I have created a presentation to you, which is, I'm not teaching you necessarily something new. I'm just revisiting what you already know. So I am revisiting the kidney anatomy and physiology, because we are about to talk about the kidneys and diagnosing kidney disease and assessing kidney function. So it's just a brief brush up on what actually is it that the kidneys do, because this is very important for how we assess their functionality. And then leads to the second part, is what kind of tests have we got available when we are wanting to assess kidney health? And there are a certain amount of primary and secondary tests. And how should I apply them in my clinical practice setup? And then the last part is about diagnosing and staging kidney disease with the inclusion of the ILIX SDMA in the diagnostic panels. And then I've added this. So it's about how do we pull the pieces of the puzzles together, because we're all looking for a diagnosis so we can initiate a treatment, right? And if we are not, if the tests we do don't have any impact on either diagnosis or the treatment, well, by all means, they might be worthless. So it's all about how do I make this as useful as possible for me. And I realize it may sound pretty dry for a Wednesday night if you spend a whole day in practice, but don't worry. In part 2, which is not my part, it will be a lot more clinical, and it will be a lot more applied to real cases from practices. So it should hopefully, at least we discussed that yesterday, all make sense in the end. But I will be happy to have any questions. I would also like to remind you and myself that while diagnostics is a very important part, you know, we've changed the pyramid here, so it all starts with the history and the physical examination, and those two can never be left out. And even the best labs in the world, the best tests in the world cannot replace your eyes, your brain, your hands, your ears, and your mind, basically. So the diagnostic tests come after the assessment, because we are making the test because we have a plan, we have an idea, we have things we want to target. So, kidney disease is common. And if you look at publications, you see different prevalences. I recently had a browse through, and I could see there was an interesting study from prevalence of kidney disease in first opinion practices in the UK. This is from the statement here of at least 1 in 3 cats and 1 in 10 dogs comes from the Merck manual, but there are different publications out there stating different things about the prevalences. And please be aware, these are based on acetemic animals, so animals who have increased creatinine and urea. Kidney disease may be prevalent without acetemia. That's a different discussion. If you look at these publications from Journal of Feline Medicine and Surgery from 2014, you can see the prevalence of chronic renal disease in cats randomly selected from 4 age groups. So there are more and more, let's say, screening studies out there. And with that, it's just a matter of reminding ourselves that kidney disease is prevalent and we need to search for it, or at least rule it out in quite a few of our patients. Now, I said I was going to go back and revisit the anatomy and physiology of the kidneys. Here comes the dry part, right? But we tend to think of kidneys as something that you assess by measuring urea and creatinine. But if you think about what the kidneys do, they have so many functions. So excretion of metabolic waste products is the obvious one, right? They are filtering things through their glomeruli. They are producing urine, but they're also retaining water, and they're retaining electrolytes, and they're regulating the homeostasis of the electrolytes. But what they're also extremely important in is acid-base balance and also the renal hormone production. So they're doing a lot of things in one go. And that means that we have already a number of tests, and because of the the diversity in what the kidneys do. There's not one test that can kind of do everything. Just 1 second. Apologies, I was just bouncing my pre-teenager off the internet. That's real life. So creatinine is a great surrogate GFR marker, but it's relatively late when you look at reference intervals. We have BUN. In an academic setting or a specialist setting, we might even directly measure the glomerular filtration rate. We have the urine, which is extremely important and should never be underestimated with specific gravity, UPC, and in some cases we can also choose to measure microalbumin. Now these are, let's say, laboratory tests, but of course there is imaging and there is a number of other things as well. If we want to categorize them a little bit, I really like putting things into buckets. That's maybe just the way my brain works. But we have some primary kidney tests or kidney markers, and we have some secondary kidney markers. And if you look at the traditionally available panels you have tests in a clinic, well, the primary ones are really BUN and creatinine and SDMA. They are all giving you an indication of the filtration. But your complete urine analysis is also really a primary kidney test. And that is all of your urinalysis, so your specific gravity, your chemical analysis of the urine and the sediment, and imaging. Quite a few renal cases, especially the congenital ones, are actually diagnosed by imaging and not by some test that IDEX delivers for you. And then we have all the secondary kits, so albumin, calcium, phosphorus, magnesium, sodium, potassium, chloride, and I keep mentioning hematocrit, cholesterol, and blood gases, not to forget. So this is just a way of trying to categorize a little bit that we have primary and secondary, and this goes for all organ systems. Now, this is not an anatomy course, but if you just remember what the kits consist of, well, the functional unit is the nephron, right? And the nephron consists of the glomerulus, and then the tubuli, the proximal, the distal, and the superciliary, and then it ends up in the collecting ducts. And these are placed different anatomical places in the kidney. So you have your glomerulus in the cortex, and your collecting ducts and your leukopenly and your tubuli partly in the medulla. And the reason why I'm emphasizing this is that you may have an injury in specific anatomical part of your kidneys that don't necessarily affect the rest. That means if you have a medulla injury of your kidneys, you may still have a completely normal GFR, but you may be pouring out protein in the urine, for instance. So depending on the markers we test, that can also help us guide towards where is the problem in this kidney. So it's a Sherlock Holmes job, right? It's trying to figure out what is happening. If we then take down to the physiology of the functional unit, well, we have a filtration, we have a reabsorption, a secretion, and excretion. This is particular in the glomerulus. So there's a lot of things happening. This kidney is doing a lot of different things. So if you look at the kidney's role in acid-base homeostasis, well, the kidney is the one organ that is capable of up and down regulating bicarb. So whenever we have a metabolic acidosis or a respiratory acidosis in particular as well, the kidneys can then compensate metabolically by secreting more bicarb. And that is extremely important. That means that when the kidneys are not functioning well, we get in trouble, because then we can't really adjust the acid-base homeostasis. And this is primarily in the proximal tubuli, the majority of this happening. When it comes to the electrolytes, again, the kidneys are extremely important because they reabsorb some of the most important ones, sodium, chloride, and potassium. But also, if you look at the proximal tubuli, they actually do reabsorb the majority of the urine. Again, so the pre-urine is being absorbed and concentrated, and then the remaining part is being excreted. Sodium is pumped actively, and potassium is usually reabsorbed passively. That's how sodium and potassium work. And then again, it's really important as well for the overall sodium homeostasis. Why am I saying that? Well, yes, because if we have an issue with the kidneys, if we have an injury to these functional units, the body may lose its ability to regulate these very important things. And I'm going to come back to potassium, but any potassium disorders are really, really physically and clinically very discomfortable for the animal. And then we're on phosphorus, because obviously the one thing we hear about renal diet is that we are ever so keen to lower the phosphorus in the diet as well as the protein. And why is that? Well, it's because 99% of the phosphate in the blood is actually reabsorbed by the kidney. Once again, we have the proximal tubuli here. So they are basically little tubuli. If the serum phosphate is high, you get to a saturation point, and then you release parathyroid hormone. So you then excrete more phosphate. If you have too high phosphate, it's directly toxic to the kidney cells. The problem is if you have chronic hypophosphatemia, you have an issue because you get secondary hypocalcemia, and you have a continuously increased parathyroid hormone because the body is trying to get these non-functional kidneys to throw out the phosphorus. And then you can develop what is described as renal secondary hyperparathyroidism. You may have seen pictures, or patients for that matter, who have this sort of very sort of special rubber jaw where the bones are completely demineralized. That's an extreme condition, but on a more mild level, it's extremely important to monitor and really try and lower the phosphate. 2 years ago, a study was published in the Journal of Veterinary Internal Medicine from the UK, where they have looked at magnesium, and this is quite a new part of looking at the bone the blood mineral balance in kidney disease. This is from the Royal Vet College, and what they found out was that because you have these secondary changes in your bone metabolism, it actually impairs the intestinal uptake of magnesium in some of these cats with CKD, especially in the late stages. So ironically enough, in the early stage, they tend to be hyper on magnesium, and in the late stage, they become hypo. And the conclusion of this study is that it's important also to monitor magnesium in cats with CKD, in particular in the early stages, where you can still make a difference. And as I said, if you have any disorders in your potassium imbalance, well, if your potassium is high, you obviously get bradycardia and vice versa. And I've just put in a picture of this lovely man who was the one who detected the sodium-potassium mechanism, and who happened to be Danish, and who also happened to win a Nobel Prize. And that was my nationalistic splash of today. But just remember that, small electrolyte imbalances can have a very big clinical implication and make the animal really uncomfortable. And I'm jumping just into cholesterol, because that's one that often confuses people when you see high cholesterol in patients with renal disease, and particularly in the mild cases, because hypercholesterolemia is always due to glomerular disease. So it's the glomerulus that's sick here, not necessarily the proximal tubuli that we were talking so much about earlier. But it's the part of the nephrotic syndrome that we relatively commonly see, particularly in dogs, where you have a marked loss of albumin. And the pathogenesis behind it is that the poor liver is wildly trying to produce enough albumin, because we are flushing out the albumin through the kidneys. And cholesterol is produced in the same department of the liver, but it's not lost through the kidneys in the same way. So the liver is kind of by accident also co-producing cholesterol, but it's not being released at the same speed of albumin. So you build up on the cholesterol in the blood. And this is actually a very pathognomic marker for this nephrotic syndrome that you see, as mentioned earlier, in dogs with proteinuria. But why are we so concerned about proteinuria? Well, because if you accumulate protein in the glomerular tuft, it becomes increased in the mesangial matrix of your kidneys. And the problem is it creates damage to the tubular cells, and then you have cell death. So protein in itself in high levels in the kidneys just as well as phosphorus, is actually toxic to the cells. And it also enhances that renal fibrosis that is often one of the things that we see in these chronic kidney diseases. So we really want to try and lower the protein in the urine. Now, that was all about the filtration part and the reabsorption and the re-excretion and so on. But please don't forget that the kidneys also have a very, very important endocrine function. And they are extremely important when it comes to producing erythrocytes and maintaining, let's say, the hematocrit within the body. Because if the kidneys are not working, we don't have the normal erythropoietin production, and that actually leads to secondary non-regenerative anemia. Ironically enough, EPO, which at some point at least was an extremely popular drug within cycling, is actually a drug for chronic renal patients. And I don't know if any one of you have prescribed it to any of your patients, but it is actually a very, very good drug for patients with CKD. And then, as mentioned earlier on as well, the kidneys play an important role with the parathyroid hormone stimulation. So they also have an endocrine function. And then, last but not least, they are very important in regulating the blood pressure. And this is angiotensin 1-2 receptor system, or the renin angiotensin system. So the kidneys are extremely important as maintaining a normal blood pressure. Basically, if you have a blood pressure that goes up, you get a feedback to the kidneys, who then release renin, and so you have this very fine-tuned receptor/feedback mechanism that really maintains the blood pressure. And of course, if your kidneys are not functioning, you lose that, and you very commonly see that chronic kidney patients, or even acute for that matter, are secondary hypertensive. And yet again, the same as any as any disorders in electrolytes, being hypertensive, they feel horrible. So that might, make the patient feel way more uncomfortable than the aspartemia, because hypertension is really clinically something that we owe our patients to do something about, if at all possible. So, we cut that long splash short. I've put in a picture of one of the control towers of Schiphol Airport in Amsterdam, because I like to see the kidneys as a control tower. And they are controlling multiple organ systems. They're controlling KLM, Scandinavian Airlines, multiple flight systems, right? And if you have renal disease, multiple homeostasis mechanisms will be disrupted. So it's not just one thing. Even if you may just detect one thing initially, please remember that there are so many other things that are being disrupted here. And any of these, systems or parts of the renal function that's not working can give significant discomfort. It's not just about the filtration rate. It's even a lot more about it than the filtration rate. So obviously there's a fair risk of a crash. This is not from Schiphol. It's just a picture I stole from the internet. I can't remember where it is, but someone accidentally drove into another airplane. But of course, if your kidneys are not working, let's say both your medulla and your all of it is not working, well, your waste products are not filtered properly. So you get accumulation of them, and you get and so on. Your reabsorption of electrolytes is not happening correctly. You may lose some, you may not reabsorb them the way you should. You can, as a patient, not control your blood pressure correctly. You develop hypertensive, and you very often see secondary non-regenerative anemia because there is not enough EPO to keep the erythrocyte production up. You may very well see a classic metabolic acidosis because the acid-base balance is disturbed, and your lipid metabolism is altered, typically with accumulation of cholesterol, at least if you have protein loss in your kidneys. So a lot of things crash in these patients. Therefore, a renal patient is a complex patient to diagnose and to monitor as well. So that's all good and great, lady, but the ones I get in my practice, how could a let's say, a set of tests look like for a clinically unwell patient? And in America, they like to call it the minimum database. I'm not sure if you use that term. We do it partly where I come from. Well, it's definitely hematology. Whether you want to do just a hematocrit or PCD, or you run a full 5-part differential, it's really up to you. What you want to know is whether, if there is a anemia, whether it's regenerative or not. That you can establish by an analyzer or by looking at your blood smear and see if you see reticulocytes. But it might be good to know if you have an inflammatory response or a stress leukogram, because a lot of these chronic ill patients you will see there is a stress leukogram indicating they've had a high cholesterol for quite a while. Cortisol, apologies. Or it might be dehydrated. Now, your chemistry panel, well, the obvious ones are urea, creatinine, and SDMA, but you really would also like to know about your secondary renal parameters, and in particular calcium, phosphorus, cholesterol, albumin, and your other electrolytes. I would say those are the most important ones if we need to pick and mix. And of course, our analysis. So the gravity, specific gravity, your depth, and your sediment. And also, just a word of thought is that you can have renal disease and concurrent morbidities as well, of course. They may have two diseases in one go. But I would say these are the ones that I would look for in clinic. But you may also want to do imaging straight away. Maybe you have hydronephrosis. Maybe you have uroliths. A lot of these cases where you see, mild acidemias, you may have blockage of one of the kidneys. You may want to do blood gases initially because you have an acidosis. You may want to check for fructosamine in case you are suspicious of diabetes. And maybe infectious disease testing. We have leptospirosis where I live. There are a lot of different infectious diseases that can cause acute renal failure as well. And of course, the imaging. So we did an exercise with our UK board-certified internists at IDEX, where we sat down and said, could we maybe come with some recommendations on which profile to run when? And this is just to show you that these are the protocols we came up with. I would strongly recommend that if you don't have protocols in your practice and you are more than 2 vets, it might be good to just, agree on what is it we do in these specific patient cases. What is our protocol for, let's say, clinically unwell cats under the age of 7, or clinically unwell cats over the age of 7, where you might want to add thyroid testing as well. Because it makes, not the world, but maybe the communication easier at least. That's my bittersweet experience through quite a few years at least. So, what can cause kidney disease? Well, just as there are many reasons for the controlled sour, or many ways the controlled sour can crash, there are also many reasons why the controlled sour can crash, or many reasons why it can happen. It can be infection. It could be cardiogenic shock, or decreased cardiac output. If you have a chronic cardiac patient, well, at some point your kidneys are going to suffer from not getting enough blood flow through. It could be stones, it could be in kidney and uterus, anything that's blocking the kidneys. It could be toxins, it can be infectious diseases, not necessarily related to the kidneys, but affecting the kidneys with secondary immune complexes. There are certain hereditary conditions, there are trauma, and then there are these weird degenerative immune complex diseases where we don't necessarily really know why it's happening. But what we do know is that the old-fashioned split between acute and chronic kidney disease is not really how it's perceived anymore. Actually, a lot of these chronic kidney disease are ongoing acute incidents. So let's say you have one case of artifacts in the kidneys, or maybe you have a little bleeding or a little something, then you restore your kidney function again, then you have a new hypoxic event, so another set of glomeruli are being disrupted, then your kidneys come back and compensate, and you have a new, let's say, acute on-chronic incident and so on. So often it is multiple acute incidents that lead to eventually a chronic kidney disease. So don't just think it's only acute or only chronic, please. The number one thing is to assess the glomerular filtration rate, and you can measure it directly. As said, we use surrogate markers in most clinical practices, at least. So the glomerular filtration rate is defined as the amount of blood filtered by the kidney's glomerulus into the bowel capsule per unit of time. So it's an estimated GFR. In humans, you actually calculate it based on creatinine and different formulas. A direct GFR is, of course, the best way of doing it, but usually we tend to do it with surrogate markers. So we have creatinine, which is the mostly well-known surrogate GFR marker. A few years back, SDMA was also released to the veterinary world as the IDEX SDMA, which is available on the Catalyst chemistry platform. Now, it's basically just a methylated form of arginine that is being produced in all nucleated cells at a state rate when protein metabolism is happening. It's been shown to correlate really well with the GFR in humans, dogs, and cats, and rats, and horses now as well. And if you have an increased SDMA, it indicates that your GFR is decreased. That's basically what it does. Now, it's a very sensitive indicator of kidney function because it's more sensitive than creatinine when you look at creatinine from a reference interval perspective. So SDMA will pick up as little as 25% loss of kidney. The average is 40% loss of kidney function where you see an elevated SDMA. It is in many cases more reliable than creatinine alone because it's not influenced by lean body mass. And that's one of the challenges of creatinine. If you're very well muscled, you will have a naturally high creatinine, whereas if you lose muscle mass, your creatinine production will go down. And the challenge is a lot of the chronic patients we see, one of the first things they do is they lose weight. So you get a negative correlation of your creatinine. So it's an early indicator of progression kidney function loss, but it can also serve as an indicator of other diseases because, as said, it's a GFR marker. So anything impacting the GFR will also impact the SDMA. So that means extrarenal causes of GFR impairment will also impact SDMA. These are relatively old documentations. Well, they came out when the test was released, and you may have seen it before, so I'm going to go relatively quickly over it. Now, studies have shown that SDMA increased earlier in cats and dogs, and these were done on colonies of cats and dogs. The dog model is a hereditary X-linked nephropathy, so you really get an animal model of renal disease. In cats, you could see it was a mean of 17 months earlier, and in dogs, it was a mean of 10 months earlier. Now, please be mindful, these are patients that are monitored very closely. So 17 months, it doesn't really help you if the cat comes in every 10 years to your practice because, that's not going to make an impact. But if it's one of those patients where the owner is compliant and they come in for a yearly checkup and so on, it can make a tremendous difference. And I think that's why, yes, it's important to diagnose these chronic kidney disease patients, but the earlier we can diagnose them, the more we can clinically do with them. And we can very rarely cure.
with us? Anne? Hello?
Can you hear me now?
Yeah, I can hear you now.
Okay, this is embarrassing. My car was turned on and it went to Bluetooth. That's how the wheel will go. Sorry about that. So when did you lose me?
Well, just at the beginning of this slide, so you just have to repeat it.
So I haven't been talking to myself for 20 minutes. That's good. Okay,
No,
I'm going to start from the beginning of this slide. Okay, so why are we so keen on detecting this, decreased GFR/kidney disease so early? Well, because the sooner we diagnose this, the more we can actually do for the patient, right? And yes, there are cases where we can cure the cause. I mean, it might be a ascending infection from the bladder. It might be, let's say, an infectious disease like leptospirosis, where we can cure whatever is happening to the patient. It might have a functional blockage like in a urethral stone. But let's face it, a lot of these patients, and the majority of them, it's a non-reversible, chronic, ongoing, degeneration of the kidneys. But all the supportive treatment we can start, the sooner we do it, the more we make a difference. So let's say once your GFR is persistently decreased to 30 to 50% of the normal, well, it's inevitable. You're going to get to end-stage renal failure, right? But the challenge is that you have these transient, reversible changes, and then they come back and they go, and they come back and they go. So the sooner we diagnose or the sooner we uncover, the more we can do. So while creatinine sometimes or often be relatively unreliable, especially in these little scrawny cats, SDMA is reliable. But please don't think that because of SDMA you can just skip anything else and that's the only thing in the whole world that will do it for you. SDMA is really a part of your kidney panel. So it's a part of how you work it up. And also, just because you haven't, if you start using SDMA, just because you haven't elevated SDMA, it does not necessarily mean you have chronic kidney disease, not at least if you only have one measurement. There are so many underlying causes that may cause your GFR to be decreased. And I'm not going to read through the entire slide because you may want to start having wine then. But obviously you can have the pre-renal causes, renal and post-renal, just like we've been taught how to categorize azotemia. So, when should you or when could you run SDMA in your patients? Well, it's really for all patients. And if the world was ideal, it would be included in all of the panels we have. It's not at the moment because it's a reagent test. But you really want to run it. You really want to run it in the more subtle cases. So that's why I made this sort of ironic header here. Back off, lady. Give me some specific scenarios and not just a fluff. Well, if you have some clinical findings suggestive kidney disease, and I'm not talking about sort of really late, but let's say you have weight loss, decreased appetite, maybe a history of polyuria, polydipsia, maybe you have a history of toxin exposure, or you have a cat that keeps coming back with uroliths or even renal abnormalities, or a dog where it's detected by ultrasound that it has an abnormal or two abnormal kidneys. That's really when it comes into play. And of course also monitoring your patients with kidney disease. And then with some of the infectious diseases where we know it can cause either primary or secondary kidney disease. Lyme disease is a big debate whether we see the same, well, we don't see the same degree of Lyme nephritis in Europe as they do in North America. But we still see patients where it does indeed trigger immunocomplex disease in the kidneys. Lepto, I mentioned before. Ehrlichiosis is a big sinner when it comes to secondary renal impairment. And, of course, some of the feline retroviruses. So that's a bit more specific. But it really doesn't make much sense to wait until the cat looks like this, because I think, well, you may want to check the thyroid on that one as well. It's just a picture I took from the internet, but it's pretty clear when you look at a patient like this that, it's not a subtle clinical thing, right? This is a chronic, you're too far in the process for an early sensitive marker to make that much of a difference. I'm sure creatinine here is going to tell it to you. So it's much better to really add it into these early, more diffuse and not so clear cases, I would say, and where you really want to rule out that there is a renal component as well. And if you then do that, you will uncover or you will experience a number of cases where you have a mild increase in SDMA. So let's say you run a panel, you have an SDMA of 16. Now what? Should I ignore it? Think, it's probably more normal. Should I go, oh my God, your cat is going to die from CKD? I'm sure you won't do that. Or do I need to retest? Is the test too sensitive? Is it going to cost me too much trouble? What do I do about it? Now, being a global company that IDEX is, we have the opportunity to really deep dive into data. So we know that SDMA is about, also the mild increases of SDMA is about 57% of all the increased SDMA concentrations. So a lot of them are the mild increases. Now the question is, how significant is that? Is it just transient? Should I ignore it? It's important. So what we did is we looked at a lot of data from North America where it's 16,000 dogs and 16,000 cats, where all of these patients had at least 3 or more SDMA results run. And all of them had to have a first one where it was normal, then at the second time point to be mildly elevated between 16 and 19, and then the third time point it could either be normalized or it could be persistently increased. So the question is, of all the ones who go from normal to having a mild elevation, how many of those will just go back to normal? Was it just whatever? And how many of them will it actually indicate that there is a persistent increase? Now, of the ones, 48% of them were persistently increased from T1 to T2. So it's almost like flipping a coin, right? 50-50. So 50% of them stayed increased, 50% normalized. So you might think, okay, well, that doesn't really make much of a difference. However, of the ones normalized, how many of those then at the third time point would then bounce back up again? And that was another 24% of the total that would actually return to an increased level of SDMA. So it looks a bit weird in this graph, but the addition is that 72% of the patients had either a persistently increased SDMA or a SDMA that re-increased again after normalizing. So it does actually show that even a mild increase is actually statistically, and it makes sense to retest them. And what is also shown in this study that I've not added any slides on is that there's no point in waiting 6 months. You may as well test again after 3 to 4 weeks. And if, and if they then, persist on being increased, well, it's time for, let's say, an iris staging. So we've tried to develop some, let's say, algorithms to help people on what to do next when you see these ones, and really split it in a mild and a marked increase in SDMA. And regardless of whether it's a mild or a marked, step number 2 is always to evaluate the complete urinalysis. And if it really is high, let's say the over 20, it's definitely something happening here. If it's in the gray zone, is there other evidence of kidney disease? If there's not, well, then you may recheck it. And here is a recommendation 2 to 4 weeks. I mean, you need to do as you see fit, and the owner says, wants to do it as well. And if it's still normal, then evaluate it another 6 months. And if it remains normal, well, then it was just one of the transient ones. If it then bounces back up again, well, you may have one of these cases where it's acute on chronic cases, where it keeps bouncing back up again. And the recommendations then are to, of course, with the elevated, investigate also for underlying diseases, manage it, treat appropriately, whatever conditions you have and comorbidities, if it's a part of your pre-anesthetic screening, you may want to adjust your anesthetic protocol. You may want to give more fluid. You may want to monitor blood pressure all through the procedure. And of course, the monitoring is about monitoring the appropriate renal biomarkers. For the sake of time, I'm just going to run relatively quick through this. These are available online if you haven't already received them. It's a little bit more in detail about investigative. And please don't forget, always, if there is any sediment or any bacteria, urine culture and MIC, if there is a positive culture, that's really important. So you have infections, make sure you treat those for the duration of time, of course. Proteinuria, as mentioned earlier, because protein in itself is toxic to the kidneys. And of course, blood pressure, really important as well. And here comes the management, of course, any underlying diseases, make sure the status is established or re-established. Don't continue with, if you can avoid it at all, any nephrotoxic medications. Again, treat your hypertension if you have that and treat the proteinuria. And here comes the challenge, because it's a little bit Jekyll Hyde, because you want to lower your proteinuria, but when you do that with your ACE inhibitors, well, you may secondary get the problem with then you increase your acidemia. So it's a little bit like of two evils. You try to minimize both the acidemia and the proteinuria. Now, you guys are the experts on treating and monitoring kidney patients, but just from a diagnostic perspective, I do appreciate that's quite challenging to monitor these patients. They're really complex patients, of course. There are guidelines out there, and if you're not familiar with the Irish guidelines, I can recommend having a look at them. They are really comprehensive and really, really good. Please be mindful that the staging guidelines are staging, they're not diagnostic guidelines, because if you look at the creatinine cutoff values, that they are quite low. So you will have a lot of patients with the normal renal function and creatinine levels above what is the staging guidelines in the Irish. So it's about staging already diagnosed patients and staging them within the 4 categories. And the early ones are stage 1 and 2. And this is where you are looking at 1 or 2 or 1 or more of these ones. So either you have a persistently increasing creatinine within the reference interval or an SDMA that is increased. You may have a persistently increased SDMA, you may have an abnormal kidney imaging, and you may have a persistent renal proteinuria. And then you have the staging guidelines, and I've added both units here because I just realized that you are, yesterday, thank you Alex, that you are using different units than we are here. So I've added both units here. And this is just to show that stage 1, 2, 3, 4, and if you catch them in stage 1, and even in stage 2, that's when you can make a difference. If you catch them in stage 3 and 4, yes, we can do things, but we cannot do that much, and we cannot really improve longevity that much, nor quality of, well, probably quality of life. I'll take that one back. And then we have the sub-staging based on UPC and systolic blood pressure. And that is also, as mentioned before, really important. So, in summary, the kidney is indeed a very complex organ, and it has multiple physiological functions. So not one test can assess the entire kidney health. It's really a puzzle, and it's a puzzle that you know, it's fun, it's interesting, it's enchanting, and it's also frustrating. The damage to the kidney can be different, let's say, anatomical and physiological regions. So the tests will, you know, the test you choose also has to be reflected on where you're looking for the injury. The number one remains to be a GFR assessment, and if not done directly, which is really not very often done, the surrogate markers are creatinine and SDMA, BUN partly as well, and of course your analysis cannot be emphasized how important that is. The secondary renal parameters are, however, very important for also getting a comprehensive picture and for monitoring the patient on a later stage. SDMA is a sensitive early marker for decreased GFR and is extremely good when used in combination with creatinine. Those two go really hand in hand, and it's not 1 + 1 = 2, it's 1 + 1 = 3. Creatinine is not perfect. SDMA is not perfect, but where one of them occasionally does weird things, the other one usually picks it up, and vice versa. In that sense, I think SDMA belongs in the panel, in particular when you're detecting early renal disease or wanting to rule out renal disease in a different scenario. If your patient looks like a mummy, like an Egyptian mummy, it's pretty much too late anyway. And please remember to also assess and treat the comorbidities besides the acidemia, because the comorbidities are probably the ones that make the patient, if not more, then at least just as uncomfortable as the impaired filtration. Now, if you're still awake, which I hope you are, please be aware that SDMA tests are not all the same. So if you are measuring SDMA on the IDEX analyzer, or if you're sending it off to a non-IDEX lab, you might get quite different results. We had a publication out, when did we publish it? 2 years ago, a Norwegian investigator where they sent paired samples to IDEX and to another lab in Europe. And that lab ran the DLD ELISA test. And what here is shown is actually there was quite poor correlation and also quite a bias between the two methods. So please don't also, let's say you have a patient where it's had a reference lab test run at the DLD ELISA last time, and then you measure IDEX SDMA on a catalyst. Please don't compare those two. Like you might end up with apples and pears. So as with most things, the methodology is really important for the quality of the results, and it's always best to stick with one methodology if you are measuring, for sure. And that will be it from me. Please, I'll have a look, see if you've typed any questions. I've also added my email address here, so feel free to send any questions or comments as well by direct email. But then from that, I will stop sharing my screen now, and we'll see if there are questions.
Thank you so much, Hanne. We enjoyed very much your presentation, and of course I've already seen it, and we have discussed a lot about it, but those were useful infos, and I'm pretty sure that my colleagues really enjoyed it. If we have some questions here, I'll be happy to raise them up and put it in the middle. But for the moment, we have no questions. So I'm pretty sure everything that you explained was really, really clear. And I see no questions for the moment.
No worry. They may ask them to you at the end of your session, so you get all the questions then.
I'll just stay here and collect.
Yes. But otherwise, as said, if you note the email, please feel free to send me any questions. Please in English, though. My language skills are limited.
Okay. How is life back in Norway? How do you feel this entire crisis? Restrictions?
So we have the same as everywhere else, where the infection rate is going up again now. So it's not gone into any kind of lockdown, but I think we can only have groups of 10 people now. People still go to work. The kids go to school. You can do sports, but in smaller groups. The big news of today is actually that Denmark has decided to call all mink of the entire country. I don't know if you've noticed, but mink is actually really susceptible to SARS-CoV-2. And what they have found out is that there is a significant amount of the people in the region where there are a lot of mink farms in Denmark that carry the same mutation as the mink do, and that can long-term impact the efficiency or the efficacy of the vaccine. So 150,000 mink of Denmark are actually to be euthanized now. So that and the U.S. election is the hot topic of today. Yeah. So that's but it's been just established that the risk for human health is simply too big. So that was the end of mink farming, for now at least. Yeah. How's it at your end?
Well, in Romania, we're preparing for elections, so that's the future. Yeah. So I'll just share my screen and
I will log off because I will probably not understand a word of what you say, but just bust me an email if there's anything, and then
I'll just explain it to you and my other friends in English. So I will switch to Romanian because I think it's easier for our colleagues. And
thank you very much, guys.
Thank you so much, Hannah, and hope to see you soon and safe. Thank you.
Bye now.
Bye. Bun, înapoi în România. Bună seara. Îți mulțumim încă o dată colegii noastre, mulțumim colegilor de la